This is my reflection on ankle decision making, and my name is Carolyn Hampton. I'm with Indiana State University Doctorate of Athletic Training. So my injury evaluation is pretty basic compared to all other injury evaluations. So I take a history and I try to spend a large amount of my evaluation in this area. Spending time talking to the patient, so I talk about things like what has happened, when did it happen, where does it hurt, what kind of pain, have you done anything for it, has it helped, has it made it worse, what's your daily activity like, have you changed your daily activity due to this injury, and has something like this happened before. So these are kind of basic questions that we can use for any injury. So specific to the ankle, depending on what their answer is, these get more specific. So next I look at the visual inspection. So this can include obvious deformity, bruising, and swelling. Third, I look for palpation. I usually start distal to proximal and then palpate at the site as long as that's comfortable and bearable for the patient. Sometimes that can be too painful depending on the injury. I have noticed that sometimes the patient, they just want you to go straight in and evaluate exactly at the site and palpate, where their pain is at. They have an issue with you going distal to proximal. They feel like you don't understand exactly what is hurting them. Next, I look at range of motion and manual muscle testing. So I do these bilaterally, and I usually like in reference to the ankle, I would do ankle, for the patient, I would say, like, bring your toes up to your nose. So I would have them do that with the ankle that I'm evaluating and the ankle that is not injured. I do not usually, depending on what this is, whether it's post-op or not, I don't usually use goniometry to measure as far as range of motion goes. I just measure it in comparison to the opposite ankle. As well as for manual muscle testing in the same sense. So then I use special tests. I usually test bone structures first, and then I would go into my ligamentous testing following that. So some things that I thought about why I do these things. A lot of why I do the things that I do, I kept relating back to, well, this is how I was taught. I was taught this way. And after I read some of the readings this week, there was a lot that, how they did it wasn't exactly how I was taught. So sticking with exactly how you learned isn't necessarily the best way. It may be the way you start out, but I think it's good to keep an open mind, and I definitely noticed that with some of the readings this week. So why I spend a lot of time on history is I really want to be able to relate to the patient and get a really good idea as to what their pain is like and how much it's affecting their life. This is something that I've gotten a lot better at recently. It's not something that I felt like I did to the extent that I do now straight out of my undergrad. Part of that is my work setting as well. I want to understand how much it affects them at work as well as how much it affects them at home. I need to know, do I need to change their job tasks? Do I need to try to help them adapt to their home life to get them by? Also, I want to identify the severity. Is this something that we need further diagnostic imaging for? Is this something that we can handle on our own? I also want to identify the abilities that they have now. So what can they do right now with their injury and what can they not do? And from those diagnostics, I look at what are the patient goals and where do they want to be? How is this affecting their life, and where do they want me to help them get to? And after that, it leads to forming a plan after this entire evaluation, whether that be the next step is diagnostic imaging to figure out exactly how long we have, or if it whether it's starting a treatment plan and figuring out how to get the patient back to achieve their goals. So, how can I be better? Some things that I have noticed that have been brought to my attention this week. Specific range of motion. I do measure bilaterally. I compare the injured ankle to the non-injured ankle. However, and sometimes I do actually take goniometric measurements, but it's something that I could do more on a regular basis, at least so that even if it's just in the sense that it could be an injury prevention, I could identify if there is a deficiency there that could be worked on, and depending on their job type or sport task, if it's something that we could work on to prevent further injuries. Also, to be attentive to specific properties. I kind of touched on this before. So in reference to the anterior drawer test that tests the ATFL, I learned with the knee flex, so they're sitting on the end of the table, and I also learned to have the patient lying supine, that you could do it that way as well. And I saw a lot in the articles, if they were talking about testing the ATFL, they always had the knee inflection. So that was something that I thought was really important to be attentive to, how the tests are performed and how they should be performed, to make sure that if you get a positive test, it could be a true positive and not a negative. I also thought of, I can jump to conclusions sometimes a lot. In the instance that if I think that there may be a fracture, or like if I refer to the Ottawa ankle rules and I think that they need to be referred for diagnostic imaging, then I could have just a slight idea that I think they need to go, and they will go, which I think is the good way to do it. However, I have worked with people in the past and I've seen other athletic trainers do this, that they may let them go through their natural healing phase and see if it gets better before they send them for diagnostic imaging. Part of it may just be my age, that I'm young and I would prefer to just send them if I'm unsure regardless. It doesn't necessarily mean that either way is wrong. Something else that I have been working on a lot in the last couple of months is to talk with the patient more than just the history. So after you do your evaluation and you have an idea of what's going on, to talk with them about that. And this kind of goes back to their goals. Where do they want to be and how does this injury affect them? And I think that that's a really important piece.